Mathilde Gras is going to present our experience of selective neurectomy. If I may, I would like to just do a little remark before she starts. We've heard it's about terminology. We've heard about neurotomy, we've heard about neurectomy, partial, selective. I think we need to use the same term for the same surgery. I think neurotomy is not a good term because we don't know if we're talking about complete or partial. So as Bertrand has been using, I would recommend to use selective neurectomy for this particular surgery. And I don't know, I hope we can agree on that. Mathilde? Maybe we need help here for the video. Okay.
Okay, so now I will present you a prospective study about hyperselective neurectomy. Or maybe not. Oh yeah. Comment? Ah, vous venez de le passer? D'accord. So hyperselective neurectomy is a partial and selective resection of motor branches. Stoffel is the first who started to do hyperselective, who do neurectomy, and he started at the lower limb, and in 1930 he did it for the first time at the upper limb. The goal is to reduce the spasticity without suppression of the useful muscle tone. And the indication of the neurectomy is spasticity, as we all said for this afternoon, and without muscle contracture. When we have a contracture, we need to add some other procedure to manage the contracture. So, if we perform the neurotomy at the main trunk, we can do some sensitive lesions. So that's why we need to do the neurectomy at the motor branch level. And so some surgeons perform it at the main motor branch, some can perform at the primary branch for the motor nerve, but we think that we really get better results if we do at the really terminal end of the nerve at the entrance in the muscle. So we can spread all along the muscle, and we can have a good repartition of the neurectomy all along the muscle, and also we can really select and be sure of the muscle we are cutting, the nerve we are cutting, but for which muscle. So the patient population in this study, it's a prospective study. The inclusion criteria, it's spasticity at the upper limb level, regardless of the age and etiology, and we looked at improvement of spasticity after botulinum toxin injection. All the patients had botulinum toxin injection, and this is really a very important tool to predict the effect of the neurectomy. And if we see that there is a contracture associated, we may add some other procedure. The exclusion criteria is movement disorder like atetosis and dystonia, and dystonia is really not an indication for hyperselective neurectomy, and we really have to pay attention of that. So the surgical technique, we perform the surgery under general anesthesia and without cura in order to get the stimulation perioperatively. So when the surgery is performed at the forearm level, we can use a tourniquet. For the musculocutaneous nerve, it's not possible. And we use intraoperative nerve stimulation. So the hyperselective neurectomy is performed as close as possible to the neuromuscular junction. So we follow the muscular branch nerve really at the end and at the entrance in the muscle. And then we can do the neurectomy. and we cut between 2/3 and 4/5 of the branches. And the resection is about between 5 and 10 millimeters. 5 and 10 millimeters. There is no immobilization after hyperselective neurectomy, except if we associated some other procedure for like lengthening or else, and then we can put an immobilization. But for really hyperselective neurectomy isolated, we don't put any immobilization, and the patient can have rehabilitation as soon as possible. So we performed a lot of cadaver dissection on 96 cadavers to have a very complete mapping of each motor branch. And this allowed us to have all the mapping, and with those dissections we discovered that we may have a very proximal branch at the musculocutaneous nerve. So this let us think that small incision is not enough, and we really need to do a big dissection to go very at the end, at the entrance in the muscle, but also to get the first branch of the motor branch for the biceps, and also I think that's it. And this we also, with the dissection, we also showed that for us it's not a good indication for the fingers, because to go to the final end of the flexors, we need to open the superficialis, and so it's very decaying. So it's not possible to open the superficialis like a book to get into and to follow the nerve. So it's not a good indication for us for the fingers. So the evaluation is performed in a multidisciplinary team with a surgeon, the rehab physician, occupational therapist, and the physiotherapist. And we looked for this study, the assessment preoperatively, postoperatively, about 6 months, and at the last follow-up. We looked at the active and passive range of motion, the muscle strains, the spasticity. At the beginning, we thought that we had to take only the Ashworth because it's more international, but it's not enough, because the Ashworth is very good to see the intensity of the spasticity, but the Tardieu gives the angle of the catch. So we really checked both, and we think that they give different information. The functional score with the house score, and the patient satisfaction with analogic scale between 0 and 10. And we evaluate goals with the patient. What do they ask for the surgery? And then we check if the goals is achieved or not. And the statistical analysis is performed with the Bayesian methods. So the results, there is 50 patients, 30 adults and 20 children. The etiology are more strokes in adults, and some brain trauma, and CP, cerebral palsy, in the children. The average age at the surgery is 43 years old for the adults and 15 for the children. There were 195 muscle, 56 operative sessions, and there were 45 cases of associated procedure. The delay between the surgery and the first post-op assessment is 5.6 months, and the delay between the surgery and the last follow-up assessment is 22.2 months. So the localization, most of them are at the elbow flexors and at the wrist level, and there is also 14 pronators. There is less at the shoulder and hand level. So you see there were 47 hyperselective neurectomy, and almost half at the elbow level. And in 45 cases, there were associated procedure, and most of them were lengthening. There were also 4 tenotomy, 3 tendon transfer, ECU and ECRB, 2 ECU rerouting, 1 wrist arthrodesis, and 1 first web widening. And in 29 cases, the hyperselective neurectomy was performed isolated. So if we focus on the elbow hyperselective neurectomy, According to the Ashworth, you see that the Ashworth score comes from 1.4 to 0.6, and then there is a slight relapse, but it still stays better at the last follow-up. And according to the Tardio scale, it remains stable with the T, and if we look at the angle, there is a slight relapse, but it's still improving at the last follow-up. For the extensor, we also have a decreasing, according to Ashworth, of the intensity of the spasticity, probably with the decreasing of spasticity because of less stress. According to the range of motion, we have an improvement of the range of motion, and it remains stable at the last follow-up. And the strains decrease a little bit, but this is not significant. For the pronation, we have the same model with a really good improvement and a slight recovering relapse of the spasticity, but it remains less than 0.3 according to Ashworth, and also with the Tardio scale. So we have an improvement and a slight relapse. According to the range of motion, we also have an improvement, and it's significant with, and it stays stable. And for the muscle strains, we have an improvement, and it also continue to improve with time. At the wrist level, it's also the same. We have a really important decrease at the post-op assessment, and then we have a slight relapse, but it remained really better. And here too, we have an improvement of the range of motion, and it's significant too at the last follow-up. And it's continue between the post-op and the last follow-up, it continued to improve slightly. And the strains also improved slightly. So the functional outcome according to House scale, improved and continue to improve between the postoperative assessment and the last follow-up. And you can see either for children and for the adults, we have an improvement, and with a global improvement 1.1 at the post-op assessment and 1.45 at the last follow-up. The goal is achieved in most of the case, and you see here for the nursing in 94 cases. In all of the cases for the hygiene, in social cosmetic, it was achieved in 92 cases. At the worst case, it's in functional and pain with 95%, which is still good results. 45 good results achieved with functional results in spasticity. And we have also 100% for the orthopedics. So in total, the goals are achieved in 90%. The resting position improved, especially at the elbow level. So the patient has a resting position better, especially for this joint. The satisfaction of the patient is 8.46 and 8.69 for the caregiver people. If we focus only on the patient who has more than 20 months of follow-up, there is 32 hyperselective neurectomy, and the mean follow-up is 36.6 months. So we wanted to see what happens after the 20 months of follow-up we had previously. Here it's the same repartition, with most of them were elbow flexors, and then 10 wrist flexors and 7 pronators. And Here we can see that the results remain stable at the 36 months follow-up, and also it's continued to improve concerning the strength and the range of motion, and the spasticity remains stable. Still for those patients, the functional house score were preoperatively 2.45. The mean score postoperatively came to 3.59, and at the last follow-up, it continued to improve at 4.1. So the results continue to improve with time. So the idea that the results are getting worse seems to be a false idea because we have the results still improving with time. So hyperselective neurectomy is effective both on agonist and antagonist muscle. The muscle strength is preserved. We have a moderate improvement of the range of motion, and Ashworth and Tardieu give a slight relapse in spasticity after the 6 months, but it is not significant. And we have a continuous improvement of range of motion and function with time, even at the last follow-up. The motor nerve, I will go quick on those slides because Thierry Deltombe already told it, but we have the motor fibers, alpha and gamma, and the sensory fibers 1A, 1B, and 2. And as he told, when we cut both of them, and the alpha fibers recover, but not the sensitive branches. So that's the mode of action of this. So we interrupted the mutatic reflex, but without decrease of the motor strength, who recover with time. According to the literature, maximal improvement in spasticity at 6 months post-op, so it gives the same results that what we found, with what Brunelli called adoption of sprouting phenomena. According to him, it can compensate up to 80% of axonal loss, adapt to the procedure so he adapted the procedure to the severity of the spasticity. The relapse of spasticity, there were 2 series comparing 6 months with the last follow-up outcome. So Kwak found that it remained stable, and Shin find the same that what we found, with a slight relapse, but it remained better, but with a slight relapse. So the take-home message: hyperselective neurectomy reduces the spasticity permanently. We have very good results, then a slight relapse, but it remains a good results, and we have to, for the spasticity, it's a good indication, not for dystonia. The surgical technique is precise with identification of each motor branch. We use the nerve stimulation, and the percentage of the resection depends on the intensity of the spasticity. There is a slight relapse of spasticity with time, but this is not significant in this study. And we have a continuous improvement of the range of motion and of the function with time, even between 2 and 3 years of follow-up. I also want to invite you to a master class on the 1st and 2nd of November. This is not only for surgeons, there is lectures, there is video transmission, and also cadaver lab, but not only, there is still some place for this session without cadaver lab, and it will end in Budapest in November. Thank you.
So maybe we start the discussion. Who wants to ask question or make any comment? Everybody agrees with everything that has been said? Or is everybody too tired? Everybody wants to go home? No discussion, no question? You have your own microphone. Fantastic. Not working. Okay.
So if you, very nice results, wonderful, and I'm with the nerves, it's perfect. But how do you deal? In my opinion, there are two problems in my patients when you're looking for the neurotomy for the flexor digitorum superficialis. Then most of them, they have a shortening. So how do you evaluate? And then you go for a lengthening on top on the neurotomy. Is that correct? And the second question is, how do you evaluate for the involvement of the intrinsic hand muscles? So these two problems, your results are perfect, and I would send every patient, but maybe you send them back because you say they have one of these two problems or so.
I explained at the end of the presentation that the indication of selective neurectomy is an indication with a very functional patient, a good case. If you have any retraction is not a good indication. And if you have a spasticity of intrinsic muscle or retraction of intrinsic muscle, is not for us a good indication. It's a very light surgery. Is necessary to have a good function. For example, for us, the best marker is the ability of the patient to have extension of the finger. Without finger extension, it's not possible to obtain a correct result. You understand? In my practice. Yes, but yes. Yes, but for us, wrist is different. There are some cases where we perform FCU, FCR neurotomy. There are a dogma in neuro-orthopedic to respect the wrist extension. But in spastic patient is not good. It's necessary sometimes to stabilize the wrist. There are some indications, I'm not sure that are included in this series, but now sometimes I perform a wrist arthrodesis in some case when I'm sure that it's possible to use the finger. Another notion is that when the patient has the finger extension, when the wrist is flexed, often we are afraid because we say, hey, if I put the wrist in right position, I lost the extensor. But in experience, if the command of the muscle is correct, with time, we observe a recovery of extensor. It's not so bad, I think. But you have to note that it's an indication for good case. It's not for the in case of retraction.
If I may add something, I think those questions you've been asking are very important questions. The first thing where we differ from Bertrand's experience is that we have decided to stop doing hyperselective neurectomy in finger flexors. Why is that? Because of anatomical reasons. From the dissections that we have done, we've done 20 dissections of the nerves to the finger flexors, and really, if you want to do a good job, you would actually have to take the FDS and open it, and then you can see the branches, and then you can do the neurectomy. And this is not technically possible. We've tried to do it at the trunk level when the nerve is actually dividing into its different branches for every single muscle. And then we have had very unpredictable results, like one works, another one doesn't work. So we don't do it anymore. So when we're dealing with finger flexors, we do only other procedures, lengthenings and so forth. So that's one difference. Second, about extension. We have to remember that these are rebalancing procedures. we're not only dealing with the agonist side, we're also dealing with the antagonist side, and we always should keep this in mind. And this is why we have so many cases of combined procedures. We do the neurectomy and we do something else. It can be tendon transfer, it can be different things, but we should always bear in mind that neurotomy is not the solution for spasticity. No, that's wrong. We really need every time to rebalance the forces that are present. I think this is, the key point to a successful surgery, especially in functional patients. And we're dealing with a number of cerebral palsy patients where very often the goal is functional. The third question you ask is a very difficult question. It is about interossei. First, diagnosis of spasticity and or contracture of the interossei in many cases is not possible before you put them into surgery, before you come to the operating room. So many times you're not even sure, if they have spasticity and or contracture of the interossei. And in a number of cases we had to go back to deal with the interossei. But we're not doing a fantastic job on the interossei all the time. I still feel in our experience it remains a difficult question.
Sorry, we have to stop because we have to stop this session because there is we have need to modify a little bit the program. So now.